Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show. Welcome to Season 4 of Concussion Corner. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. Jaclyn Caccese back with us for part 2 of her interview. Dr. Caccese is an assistant professor in the School of Health and Rehabilitation Sciences at The Ohio State University College of Medicine and a member of Ohio State's Chronic Brain Injury Program. She completed her BSE in Bioengineering at the University of Pennsylvania and a master's and PhD in Biomechanics and Movement Science at the University of Delaware. Her research focuses on understanding the short and long-term effects of contact sports participation and sports-related concussion with the overarching goals to inform public policy regarding youth sports participation and to improve outcomes in current and former athletes. Through her research, she aims to determine changes in sensorimotor processing following concussion, the relationship between age of first exposure to contact sports participation and clinical outcomes, and interventions to prevent injury and to enhance recovery. Dr. Caccese has 31 peer-reviewed publications and has presented on these topics at regional, national, and international conferences. Jaclyn, welcome back to Concussion Corner.
Thank you for having me back.
It's good to have you again. It's Brain Injury Awareness Month, and we hope that folks consider sharing our podcast with 1 to 3 colleagues. Super easy. Just let people know that hey, we're offering free open access medical education with with researchers who are doing the actual work out there and sharing their literally like life's work. So it's a pleasure to have you on and to discuss your dissertation and some of the work that you've been putting in lately with persistent visual and vestibular impairments for postural control with concussion. So I'm super pumped to have you on and have you on for part 2.
Great. Yeah, looking forward to it.
So in terms of your dissertation, I would love if you can just kind of clue in the listener to kind of let them know, like, hey, how long did this take? What was this process like? And how did you come to the conclusion of the actual topic of your dissertation? I guess we can start with that. But really, I think letting people know, like, hey, the deep work that goes into putting something together like that.
Sure. So I would say that all in all, it took me about 4 years. With that being said, most of the first 2.5 years were kind of prep work, reading and learning about the topic, diving in. And then the project actually was about the last 1.5 years. So just to give you an idea of the overall time frame. So I was interested in soccer heading. I went to the University of Delaware to study soccer heading. As we talked about last time, my background is in engineering. So I was looking forward to studying the biomechanics of soccer heading. And we did a number of studies on the field. One of the challenges with doing research on the field is that there are a lot of factors that you can't control for. And we learned that pretty early on in the study. And that includes like the limitations with sensors. So one of the problems with some studies that use instrumented headbands or mouth guards is that there is a high rate of false positives, meaning that there's a lot of stuff going on that isn't necessarily head impact, right? So these are accelerometers that are designed to measure any time an acceleration occurs. And so in women's soccer, that includes fixing your hair when you take off the headband and you tie it around your wrist and you fix your hair and then put it back on. That includes when it falls off and people run over it the entire game. And then there are also factors that are real, but just impossible to control for on the field. So things like ball speed, right? Whether you're heading the ball off of a throw in or a punt or a, another kick, all of these things affect the magnitude of the acceleration. Even the pressure of the ball affects the magnitude of the acceleration. And so the challenge with that is that those are all factors you can't control for if you want to look at some specific variables. And so what we were interested in is, in a very controlled setting, what are the factors that affect head acceleration? So the magnitude of the head impact during soccer heading. And so we used a controlled soccer heading paradigm. So we brought athletes into the lab. We had them head the soccer ball from what's called a jugs machine. So if you've ever played soccer, you've probably seen one of these. A lot of times you would use it for like trapping drills, or they'd use it for goalkeeper drills. But essentially it's two really big wheels, looks kind of like car wheels, and it projects the soccer ball. And you can control the speed of the projection to an extent, right? Like it's probably not completely the same speed every time, but within a pretty narrow range. And the trajectory, you can make sure it's going straight. You could also turn it if you wanted to, but in this case, we were doing linear headers. And also the angle of projection. So it's more or less the same ball every time. And so the athletes came into the lab and they headed the ball. It was a total of 12 times. We wanted to give them some time for warm up. So they had the first two were like practice headers, just to make sure they understood the task and they knew what they were trying to do. And their goal was just to head the ball back in the direction from which it was projected. And while they did this, we had them wear a bunch of markers around their trunk and their head and neck, so that we can look at their kinematics, like how their body moves when they're heading the ball. We also used EMG, electromyography, to measure the activity of some of the muscles in the neck, specifically the sternocleidomastoid and the upper trapezius. And then they were instrumented with a headband that had an accelerometer to measure linear and rotational acceleration during the heading task.
What headband did you use, Jaclyn?
We used the Triax headband, which is no longer in existence.
I was just going to say, I thought that one. Yep. Okay.
Yeah. So I think they may have switched gears and now they're doing maybe like construction or something like that. I think the company might still be around, but they just don't make accelerometers for sports biomechanics assessments anymore. With that being said, that's certainly one of the limitations of this study. It would have been probably better to use a mouth guard accelerometer because they are more rigidly attached to the skull, in the sense that a headband could possibly move when you're heading the soccer ball. We tried to reduce that by really making sure it was secured to the head. But I think that is certainly one limitation. We just didn't have access to mouth guard accelerometers, and it kind of wasn't feasible for the purpose of this study because the mouth guard accelerometers, you have to get fit for each athlete. And we were trying to bring 100 athletes into the lab. So that would have been a lot of mouth guard fitting.
Yeah,
so we used the headband.
Yeah, I don't endorse anything at all here, but I do like the mouth guard accelerometers just because they are fixed to the the patient's skull, via
Yep.
the maxilla. So yeah, I totally hear that, but I can understand. Holy wow, that would be quite the job to get that done for over 100 participants.
Yeah, and I think that different sensors are becoming more readily available now than they were at one time. For a long time it was just the hit system in football, and now there are a number of different mouse guards that are coming onto the market. With that being said, again, I don't endorse any particular one, and there are certainly limitations, and I don't think it's really ready for prime time like a clinical tool yet. But there are improvements, let's put it that way.
Yeah, and I would love to just interject for a second and just have a quick side conversation, and then we'll come back to your dissertation. But for folks that are curious about this, who may be working in the coaching environment and things like that, and are also clinicians or researchers, what are some of the limitations, and why is it so difficult to say like, hey, we can't just throw accelerometer on a kid and then what happens is traditionally, we're on the sidelines, and a parent or someone is watching this data that they may not know anything about. And again, you've already kind of alluded to, it falls off, it gets run over, they put the ponytail on. But again, why are we using this? Why aren't we using this in every youth soccer, youth football, softball game? To quote unquote monitor concussion. And it was a kind of a softball setup for you there, but I think it's really important to talk about this.
Yeah, I think that I already mentioned a couple of the limitations, which is that, you really need video surveillance to make sure that the impacts that are coming in are true impacts, as well as that you're not missing them, that somebody's not wearing their sensor or something like that. And they are coming up with alternative options for that. Some of the mouse guards have sensors to help you determine whether the mouse guard is in the athlete's mouth at the time, which is a good starting point. They're developing algorithms to try and determine if an impact is a real impact or not. So I think at some point, those things will improve. It's just kind of a slow process that, a lot of the research is moving in that direction, but we're not quite there yet. I know Christy Arbogast's group at CHOP is doing an awesome job trying to get some of that information out in terms of, alerting people, hey, we need to make sure that these impacts are real impacts. But the other side of that is that we also don't know a lot about the impacts themselves.
Great. Yep. You set yourself up. Thank you. As an interviewer. Yep. There we go.
So, in terms of determining like a quote unquote concussion threshold, actually some of the data from the CARE Consortium and from other groups, especially the VATEC group, is certainly making our way there in terms of looking at individual thresholds. So like based on your previous head exposure history, can we determine, what level causes a concussion for you specifically, relative to control participants who didn't experience a concussion, but maybe the same position and the same size and same weight. And so all of these things are helping us learn more about it. It seems like thresholds for youth athletes may differ from collegiate athletes, and maybe helmeted and non-helmeted sports differ. So I think we're starting to understand more, but we're definitely not to the point where you can, put a mouse guard with accelerometers in an athlete and tell them whether or not they got a concussion.
Indeed.
Concussion is very much a clinical decision.
Yes, and just to reiterate that, yes, concussions are clinical diagnoses only, and it's important to connect to that. And again, from a clinician standpoint, from my lens and my world, even as someone who's had some concussions in her life and a prolonged recovery with my last one in 2013, historically, anecdotally, we see, from subjective reports and things like that, that thresholds do decrease over time with previous head injuries. So that's awesome to see that Christy Arbogast at CHOP and those folks are studying, what these thresholds are. That will bring me back to you. And can you actually talk a little bit, I first heard, I think it was Grant Iverson talk about this years ago, but the difference between linear and rotational acceleration and why someone may be able to take a hardier threshold, okay, like a magnitude of of a head impact or body impact with a linear acceleration hit as opposed to a rotational one. I would love for you to be able to discuss those two things.
So I think we actually know a little bit less about that than some may think in terms of the trade-offs between linear and rotational acceleration. So I guess the easiest way to describe it is linear acceleration would be like a straight-on impact. I guess like if you think about a car going straight into a pole, actually that's probably a bad example.
Or just like
I wish I had practiced how to explain it.
Well, that's okay.
So let me try this again. So linear acceleration is kind of the straight on motion versus rotational acceleration, which is rotation. Oh, geez. Okay. Let me think about
again, rotational acceleration, right? If we talk this through is, you're going to have some different forces to the head, to the neck, and to the body, right? I mean, I'm assuming comparatively to a linear impact, right?
Right. I think like in its simplest sense, linear is straight on and rotational is a turning effect. And so if you have a linear acceleration, one way to think about it is if your car is accelerating forward, right? It's very linear. Versus if you see somebody get punched on the side of their head and their head rotates. Now it doesn't have to be rotating in that plane, right? It could be if they get hit straight on and their head flies back. But the point is it's that rotational component. It's a turning component as opposed to linear acceleration, which is more straight on. And so, there have been a number of studies that have tried to disambiguate the linear and rotational effects. And some of the work suggests that the rotational acceleration may be more related to injury. But I think it's still certainly up for debate. And then there have been other studies that have tried to combine the two and calculate like a joint metric based on linear and rotational acceleration. And so I think we're still trying to understand, what different thresholds are for linear acceleration, for rotational acceleration, for the combination of the two. And so I think, a lot of whether it's linear or rotational depends on the type of impact, where your head is hit, all of those things. And so not only understand that, but then also at the brain tissue level, right? I mean, we're measuring how the head is moving and using that to estimate how the brain is moving. And those two things we think are related, and there's some evidence to suggest, some modeling evidence to suggest that that's true. But trying to understand how those linear and rotational accelerations translate to brain tissue level stress and strain is definitely another area of interest in research.
Indeed, yeah, and I'm also interested in the vestibular component as well, with a lot of that rotational accelerations that we're finding, and just clinically, we see folks much more effective clinically, vestibularly when they have a hardy rotational injury. So I'm looking forward to kind of hopefully that we keep continuing to do this research. And again, there's so many mitigating factors to, I'm sure, research on this, but clinically, that's what I'm seeing in clinic with patients.
Yeah. And if you think if you think about it too, it's also interesting because we essentially have those linear and rotational accelerometers in our head already, right? I mean, like the otolith organs versus the semicircular canals, measuring that linear acceleration versus rotational. So I think that, you know, we're nowhere near understanding that relationship, but there's definitely something interesting there.
That's all. It's all good. So let's definitely finish talking about what you found with your dissertation. And I really do want to hop into, as we finish up, into your persistent visual and vestibular work as well. So in terms of what did you find, what were your findings with your dissertation in terms of head and neck size and neck strength and things like that?
Yeah, so the first paper out of the dissertation actually compared soccer heading in men and women and across youth, high school, and collegiate athletes. And what we found there is that during the controlled heading paradigm, women had higher head accelerations than men. You know, this may differ from on-field play, but this was in a controlled heading paradigm. And then the second part of that was to understand what factors were associated with these higher magnitude impacts. And so what we found is that both head and neck size as well as neck strength were associated with the impacts, such that if you had a relatively larger head, larger neck girth, higher neck strength, that was associated with lower acceleration, which in this case, lower is better. And so the next step in this, if you think about it, like your head mass, you can't change that, right? Like there's not much you could do to change how big your head is. But from a neck strength aspect, we can target neck strengthening. So one of the things that we're trying to do is use neck strengthening as an intervention to try and mitigate forces during head acceleration, or mitigate head acceleration during soccer heading.
Awesome. Yeah, and it's so nice to see that you actually objectively found measures that we've been talking about for years, right? So it was so, you know, and this is why we need folks like Dr. Caccese out there to actually do the work, you know, that none of us clinicians want to do. Again, right, we want to be treating patients and putting hands on patients and being in the clinic, as opposed to someone like you. But it's so nice to be able to translate that research and evidence, you know, back onto the field, literally. So, you know, thank you for doing the work that you did there.
Yeah.
So, you know, we'll finish up, you know, as we have the last 5 or so minutes. I would love to talk to you, especially as a physio, about your recent work on persistent visual and vestibular impairments for postural control after concussion. I know that you're still in manuscripts with this, but I would love to discuss what you found, and then also a little bit about the language that's in this, in your future article about sensory reweighting. So what did you find with this study, and let's go from there.
Yeah, so I think maybe setting up the paradigm will address both your sensory reweighting question and kind of allow listeners to understand some of our results or interpret some of our results. So humans use sensory reweighting to balance. So what that means is that you can adjust how much you're using each sensory system. So our 3 sensory systems for balance: visual, vestibular, proprioceptive, right? So our eyes can see the environment around us. Our inner ear vestibular system kind of tells us how we're oriented relative to gravity. And then our proprioceptive system, the sensors in our muscles and joints that tell our body how it's positioned in space. And we adjust our weights of these sensory systems based on how reliable that sensory system is, how reliable the information is, how much noise is in that system. And so the more noisy a signal is, the less you rely on that system. And if you think about it, if you totally take away a system, then you have to rely more on your other systems. So in the paper, I think I give the example, if you walk into a dark room. If you walk into a dark room and you can't see, then you can't rely on vision for balance. So you rely more on your vestibular, your inner ear balance system, as well as your proprioception. And so this study was designed to look at that sensory reweighting. So we had people stand in a virtual reality cave, and we used visual field motion. So on this virtual reality screen, there were about 500 pyramids that were positioned randomly across the screen, and those pyramids moved back and forth. And what you do is your body actually entrains to that visual stimulus, which means that you start to move with the visual stimulus. And then at the same time, we also had vestibular and proprioceptive perturbations. So for the vestibular perturbation, we used galvanic vestibular stimulation, abbreviated GVS sometimes. It's a pair of electrodes that you stick behind a person's ear and you send a current to their vestibular system. So if you think about the orientation of the vestibular system relative to, you know, that area behind your ear, you can get pretty close there and send a current and kind of bias your vestibular feedback. And so we did the same thing where we sent like a sinusoidal, like back and forth current so that they kind of felt like they were swaying forwards and backwards. And then at the same time, we used vibrators attached to their Achilles tendon, and these kind of bias the proprioceptive feedback. So they would turn on and off, and that would cause individuals to sway back and forth. And so all of these were done at different frequencies. And the advantage to that is that then we could look at how much a person sways at each of those individual frequencies. So we could see how much they're relying on visual information, how much they're relying on vestibular information, and how much they're relying on proprioceptive information. And what we found in the study is that individuals relied more on visual and vestibular information, which at first is kind of counterintuitive, because usually if you have more noisy sensory feedback, you would think that a person would rely less on that system. But they were both higher. And so one of the thoughts there is that we might be using multiple sensory systems to kind of validate that information. So if both vision and vestibular are really noisy, then you would want to use both at the same time to make sure that what you think is happening is actually happening. And so the example, an example there is like older adults do this, right? So as individuals age and their sensory systems start to naturally degrade, they have to use more sensory information to maintain balance. And so I think that may be something that's happening here. Now, what was interesting is that the resultant sway was much higher. So people just swayed a lot more, which could also result in higher gains, right? If you sway more, it will look like you're relying more on the sensory information, even though it's just that you're swaying more altogether. So that's definitely a factor. But what we found is that the sensory feedback still seemed to be somewhat impaired in the concussion history group. So in this study, we had 3 groups. We had a recent concussion group who was between 2 weeks and 6 months post-injury. We had a concussion history group who was more than a year out from their most recent concussion, but at some point in the past had a concussion. And then we had a control group who never had a concussion. And both the concussion history and the recent concussion group had higher gains to visual and vestibular stimuli. So they swayed more as a result of visual and vestibular stimuli. But the recent concussion group had worse balance all around, whereas the concussion history group seemed to, their overall sway seemed to recover, but their reliance on the sensory feedback didn't really recover. So whether it's a matter of recovery or compensation, it seems like it might be more a compensation mechanism where they kind of learn to use multiple sensory systems to balance. And then that kind of helps improve their overall sway. But I think we still need to kind of dig in deeper to disentangle those possible mechanisms.
Yeah, and I think just to, connect to that clinically, from being in practice is that, we see folks 5, 6, 7, 10 years out that, have had some compensatory measures in their life to function, to get around New York City, or if they're in the military, or what have you. And then we can actually kind of train those things out of them, to help them adapt from a neuroplasticity standpoint. So I think that's interesting that you're definitely on the cusp of, connecting to some of the things that we've been seeing in clinic.
Yeah, and see, what we don't know is in this study, any type of rehab that the participants experience. We weren't able to control for that. And I think that's something that we're interested in the future. So if you have these individuals who do have high sensory gains, problems with visual and vestibular processing following concussion, if they undergo vestibular rehab or vision therapy, like, will that, it almost certainly will improve their postural control, but will that correct for some of the later or long-term effects?
Yeah, and I definitely think it's a good conversation to be having, just because that's one of the biggest questions that we have as clinicians in terms of frequency, intensity, and dosing of our rehabilitative, prescription. So I'm definitely looking forward to kind of seeing where all of this research is happening, and it's just so nice to see all of this being done in the first place. Because again, most of our work, we just celebrated our 100 years at the American Physical Therapy Association, which I'm one of our spokeswomen for. And, again, we literally started the world's largest organization for physios literally 100 years ago this month in New York City at a steakhouse, actually, Mary McMillan and her crew. And literally everything we've done early on has been in the absence of evidence. So it's so nice to see the presence of evidence and folks like yourself doing the work. So I really appreciate what you've been doing, early on in your career.
Yeah, I appreciate the feedback as well.
So, as we wrap up here, Jaclyn, where's the best place for folks to find you on social media? And we'll make sure to put all of your contact information for your lab and the work that you're doing over at Ohio State in the show notes.
Great. Yeah. Individuals can reach out to me on social media. My Twitter handle is Jaclyn Caccese, JACLYN _CACCESE. And all of my contact information is on my OSU webpage, so you could check those out as well.
Awesome. And for our listeners, just to recap, we talked about age of first exposure and repetitive head injury and why those two things are important to look at and have a conversation and do research on. We talked about sensorimotor processing and reviewed some of Jaclyn's dissertation on soccer heading, biomechanics and neck strength and linear and rotational accelerations. I'll have all of those links to her articles, either PubMed or Google Scholar, in the show notes. And again, it's Brain Injury Awareness Month. Please reach out to a fellow colleague and just share this podcast with somebody, just one person in your network. And let's try and get this information out there to folks that are in clinic, in practice, and may have certain questions or very Dunning-Kruger-esque may not know what they don't know. So again, Jaclyn, thank you so much for coming on. And we really look forward to seeing kind of where your research moves forward in the future.
Yeah, thanks for having me. And hopefully we can fill in some of the missing gaps in the near future.
Indeed. All right. Take care.
Thanks.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.